Hi everyone. Here we have handy references for those important and common values in adult echocardiography. And for pediatric, I am going to prepare another clip. At the bottom of this clip, you will see the timeline. Whatever you need, what parameter and value you need, just go and find it and click on it, and it goes right away on that parameters. And after each parameter value, I am going to talk about a little those practical points and tips that help you when you do those measurements. And beside of that, I am preparing and uploading the PDF format of this lecture and put it and share it on the community so you can have it always with you in your cell phone whenever you need. You can check it out. I hope it is useful and you enjoy it. Now let's do it. Here we have for the IVSd interventricular septum diameter and posterior wall. I am holding 5 seconds for each value and parameter, then I go to the those tips and practical point. Unfortunately, many tech still they measure a wrong way for the PLAX or even M modes for the IVS, posterior wall, and LVID. The most important principle for measuring uh, those parameters in PLAX or PZAX is that our measurement should be perpendicular to that structure. And for the left ventricle, our spot is exactly at the tip of the level of tip of the mitral valve closing in the diastole, and our direction of the measurement should be perpendicular to the left ventricle long axis. This is left ventricular long axis, and our measurement should be perpendicular or orthogonal to this axis. So, since I mentioned many times, one basal part of the left ventricle in most patients is rectangle. Any spot from the tip to the papillary muscle that our line measurement is perpendicular to the both septum and posterior and left ventricle will be correct. So we can measure here, 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 all the way. Most and I notice many tech they measure at the exactly tip of that based on the view that you have it. If you're a little with heel to oblique, left ventricle become oblique, this measurement line will be completely wrong. Doesn't matter 2D or M mode. If you put cursor this way, you are off axis and we are overestimating for all those parameters. The only way you can make it correct that you twist your cursor. Some machine they have AMM option, then you can twist it and make it cursor parallel to that structure. Another important point is that at the level of the aortoventricular junction, septum in some cases is thinner, or we have sigmoid septum here. In those cases, we shouldn't measure at those spots. We go a little beyond more distal and then we measure it. If the patient has a significant sigmoid, we measure separately sigmoid and show that we have significant and thickness of the sigmoid septum. For example, if on this view we want to do a measurement by M mode, if we put cursor at the tip of the mitral valve, as you can see, is completely off axis, and that is completely wrong. The only way we have to twist it our cursor, make it perpendicular, any spot between the tip to the papillary muscle and perpendicular to the left ventricle, and that will be right. Or I prefer do it M mode. 2D, sorry. 2D for that one is just only any spot for that, and you can measure it diastole and systole. The most important part for this doing systolic Most of the time systolic will be off axis. That is the very easy and simple reason, because heart shaking left and right a little and moving. So during diastole and systole, our cross section will be not the same. That is the reason I usually doesn't recommend measuring systolic. But if you are or your department is very obsessive about the systolic measurement too, make sure that your during systole your heart doesn't get off axis. What does mean off axis? Tip of the apex left ventricle, if you're rocking and see the left ventricle, tip of the apex shouldn't move during systolic more than 5 to 6 millimeter in. If it goes more than amount in, that is off axis, and all measurement will be wrong, and you are overestimating ejection fraction, LVIDd, systolic, all those parameters that we calculate on systolic. Generally, systolic is not a good idea on the PLAX. But instead of that, we can do those measurements in the short axis, 2D or M mode. That will be much better for many reasons, because first of all, you have to make sure your view plane at be between tip of the mitral valve here, fish mouth, and you can see anterior mitral valve leaflet suddenly become a little separate, means you are beyond the tip of the mitral valve, or completely loose and you see just part of the mitral valve leaflet. That is your view up to the papillary muscle. And second, with twisting and moving up and down, and I explain now, they can make it circular shape. If it's not circular, your off axis and measurement will be wrong. After you got a circular shape at tip of the or up to the papillary muscle, then you go at end diastole and end systole. At this line, you measure your 2D or put cursor for M mode. Just make sure your cursor or your measurement pass through exactly at the center of the left ventricle. In that case, it will be almost 100% correct. My strong recommendation is that whenever you are suspicious any abnormal dimension finding on PLAX, you measure it, just go with PLAX and see if they are corresponding with each other or not. But you have to remember that the measurement doesn't matter 2D or M mode. On the PLAX is usually is 5 to 10% more than measurement on the PLAX. For many reasons, the most important reason in being off axis on the PLAX, and resolution on PLAX is much better accurate. So just keep it in your mind this important tip. You have to remember that the thickness of the myocardium from the base to the apex gradually decrease. And not only that, at each level, especially at the basal and mid level of the left ventricle, the thickness of those wall and segment, they are not the same. Usually, most of the cases or many of the cases, you can expect to have different thickness, about 5 to 10% differences between each of those segments at each level. For measuring left ventricular mass, we have three techniques: linear, 2D, and 3D. In linear, the same that we do measuring on the PLAX or PLAX by 2D or M mode. At the end of the diastole, we measure IVS, LVIDd, and posterior wall thickness, and the machine or ourselves, we put it on this formula, left ventricular mass will be calculated. On 2D, if we use cal on the machine, that most machines, they have it, on the name of the left LV mass. We go on the PLAX at between the tip of the mitral valve and papillary muscle, that level. Then we trace it. We select the option epi and endo. Epi means we tracing outside of the left ventricle. and endo, we trace it inside of the left ventricle. Then we go apical for at the end. This is at the endoastole. This is at endoastole too. At the end of the endoastole four chamber, we measure left of the left ventricle length from the apex to the middle of the mitral valve annulus. In this case, we measure LV length axis. Then machine calculate by the formula truncated ellipsoid formula, calculate left ventricular mass index. 3D, there is an option for 3D. We measure outer, inner, and PLAX, those options, then machine calculate for us left ventricular mass. For categorizing of left ventricular mass and hypertrophy, we can use the parameter of relative wall thickness. For that purpose, we go measure posterior wall multiple 2 and divided by left ventricular internal diameter at the diastole. And based on the left ventricular mass, if it's normal or abnormal, and the RWT, we can categorize in 4 groups: concentric remodeling and normal geography, concentric hypertrophy or eccentric hypertrophy, based on those left ventricular mass and RWT. Here we have left ventricle internal diameter at the diastole in male and female, and left LVIDd index that is based on the body surface area. In body surface area, can calculate by this formula based on the height and weight. All those tips that I mentioned on the PLAX measurement, IVS and LVIDd on 2D and M mode, it goes for this one too. Here we have left atrium AP anterior posterior diameter on the PLAX. All those tips that I mentioned here, it goes the same for the left atrial dimension AP measurements that you can check it on the other clip. For measuring for the LAAP dimension, we have to follow the same rule and concept that I mentioned on the left ventricle dimensions. Means our measurement should be perpendicular to the left atrial long axis on this view. PLAX, for example, here, this will be our left atrial long axis. So our measurement will be this way. So if you put on this, for example, in this case, we do M mode or 2D, doesn't matter. On M mode, if you put cursor at this level that we put it at the sinus wall solo for left atrium, the same, that will be wrong off axis. The correct one will be, we have to twist our cursor this way, perpendicular, or measuring on 2D on this line or plane. The measurement for the M mode is leading edge to the leading edge, means outer to inner, but for the 2D will be inner to inner, perpendicular to the left atrial long axis. Here we have thoracic aorta, root and ascending aorta. For measuring thoracic aorta as root and ascending, we go on the PLAX, zoom in at the level of the part of the LVOT and ascending. Then at the end of the diastole, we measure inner to inner at the hip that is become aortic annulus, root annulus. Then we have sinus tubular, sinus valsalva, outer to inner or leading edge to leading edge, and then sinotubular junction. Again, leading edge to leading edge or outer to inner. Don't forget don't include the right ventricular outflow because this has two walls and between them I explain on the aorta measurement. For ascending, we go a little off axis on as much as you can get it the distal of the ascending aorta. Then we go measure the distalest part, that largest and largest spot at the end of the diastole, outer to inner. Whenever we have significant dilatation of the or enlargement of the aorta at any spot, it is a good idea we measure all those four dimensions. Here we have left atrial volume. Top row is area, and the bottom is LA volume index. That is based on the body surface area. When you are going to measure LA volume and index on apical 4 and 2, with twisting and fanning at apical 4, twisting counterclockwise and clockwise, make sure that you have all four chambers at the largest size at the same time. That will be your view. Then when you trace it, start from the septal hinge of the mitral valve, trace it, don't include uh, pulmonary vein, appendage, and make sure here we have thoracic descending aorta. Many times the wall between them will not be clear. So almost should be symmetric both sides, some elliptical or oval shape or rectangle close to the rectangle. If you go too much, your tracing go too much in and out, most probably you don't have good image. Try get it good image. At the end, the length of the left atrium should be almost perpendicular to the mitral valve annulus line here. Uh, just with moving left and right, and make sure your length is crossing over the line or exactly over the line, not be above or below that one. Here we have right atrial diameters and volume in female and male. That is the absolute number of the area on the right atrium. Here we have volume and diameters, major and minor diameter and index. For right atrial dimension and measurement, just make sure you have clear image and in the apical 4. Then for area, you go at the hinge of the tricuspid annulus, trace endocardium of the right atrium and finish it to the annulus. Just remember, insertion of the tricuspid valve annulus is a little more apical compared to the mitral valve annulus. Then for the dimension major, we go make it a line from the posterior to the center of the tricuspid valve ring at the center, middle of that, as much as possible perpendicular. And then for minor dimension, we go make it, find it the largest spot on the transverse here, then make it perpendicular to that major axis at the largest inner to inner. That will be our minor diameter. Here we have the normal and abnormal value for ejection fraction of left ventricle. In two other clip I mentioned about ejection fraction, eyeball guessing and tracing endocardium very in detail. But just remember, in those cases that you don't have very clear endocardium and you don't have access to the any contrast, but you want to give a number, get a general idea about the ejection fraction. In those cases and in other cases, MAPC and MAPS-V, that is M mode, and the tissue Doppler MAPC, and tissue Doppler is MAPS-V. It can give us a good evaluation for ejection fraction. We do it on the medial and lateral both. We measure, and then we measure mean MAPC. That if is mean MAPC is over 8 millimeter, most probably ejection fraction is normal above 50%, and if it's below 7 is ejection fraction drop. Just remember MAPC and tissue Doppler on the annulus. When we have cardiac surgery or mitral or aortic valve calcification or replacement mitral valve or aorta, those will not be too much reliable. Here we have left ventricular volume in different gender and volume index 2, and grading of the enlargement or dilatation of the left ventricle. Here we have chart for those volume on the left ventricle and 3D measurement for left ventricle and diastolic volume. Here we have right ventricle dimensions, just for reminding: proximal on the PLAX, proximal on the PZAX, distal on the PZAX, RVOT, all of them. Here we have diameter, basal, mid, and length, and here we have area of right ventricle and diastolic area. Here we have the normal and value for the right ventricle area, volume, and function, including TAPSE, S prime, strain, and everything, myocardial performance index. Right ventricle myocardial performance index or RIMP can be evaluated by two techniques. One of them is tissue Doppler, another is pulse width Doppler. For the tissue Doppler, we go put it on the TDI tissue Doppler and then sample volume at the lateral tricuspid annulus, and then we measure ejection time and IVRT and IVCT, or time of closing and opening of tricuspid valve. Then we put it on this formula. We can calculate MPI of the right ventricle, or we can go do 2D. First, we go on the pulse Doppler at the tricuspid valve on the apical four chamber. We measure TCO, and then we go PZAX and LVOT, sample volume, pulse width Doppler. We measure ejection time. Then again, with that formula, we can calculate MPI of the right ventricle. I hope you like it, and please don't forget, share it. Up to the next time, have a wonderful time.